My first takeaway is remember that we're humans here, both yourself as a clinician and the person who's seeking care. It's okay to communicate things that you're still uncertain about with a person who's crying, console them and not be stuck into thinking I got to get this done to document for insurance purposes. Like we need to be greater than that. We need to see the humanistic side of care.
Hi, this is Amy McDevitt on the AOMT Hands-On, Hands-Off podcast. So today we're going to be talking with Mark Shepard. Mark is an associate professor at Bellin College. I'm going to let him fill in more of the gaps, but I've had the pleasure of knowing Mark. I was trying to reflect on it, maybe 6 or 8 years. But I've really enjoyed working on various projects. Mark has been super collaborative, so I've really utilized his brain if I'm stuck on something, or, I really love that you're always kind of pushing contemporary ideas and trying to integrate that into physical therapy education and research. And so anyway, I really appreciate you, and I'm excited to just have a conversation about some of the things that light you up and blow your hair back. So I'm going to let you start out by talking a little bit about yourself, both professionally and personally. So tell us a little bit about what you like and who you are.
Yeah, thanks, Amy. And same back to you. I enjoy, geeking out over clinical reasoning, which I know is a big passion of yours, as it is mine. So looking forward to chatting today. But I personally live just about 20 minutes south of Baltimore in Maryland. Been here since 2010. And love the area. But my day job is with Bellin College, which is located in Green Bay, Wisconsin. So I work remotely with the school. I travel there periodically to do on-site immersive labs with both the DPT program and the fellowship program. So I split my time as a program director of the fellowship program at Bellin College, and also teaching in the entry-level DPT program. So I kind of have a dream job of working kind of at both ends of the spectrum. People just coming into the profession, and then people who've been out for several years all the way. I mean, we've had people in the fellowship who have been practicing for like 30 plus years. And so I feel like I'm learning, just as much as any of these individuals in the programs I work with. But it's just super fun to be at both ends of the spectrum. And teaching and learning in that type of environment. And clinically, I work for Johns Hopkins Rehab Network.
Okay.
And so I've worked for them full time. I'm now per diem, given the teaching and other types of roles I have. But I really find it super helpful to stay in the clinic. A lot of the things that I feel like I've been thinking about over the years have been birthed from clinical practice. And teaching helps me in the clinic, and the clinic helps me in teaching, and it keeps me grounded. There's nothing more humbling than, being in patient care and having someone tell you, like, oh, this is not helping or something like that. So I think it's nice, it's nice to be in the ivory tower of academics, but I love just having that true person-centered care that really keeps me grounded and humble.
Yeah. I agree. I love being in the clinic. It's such a different hat to wear, I suppose. What patient population do you tend to see when you are in clinic?
Yeah, I pretty much see toe to like the head. So, I luckily for my own fellowship training that I've been through, it's kind of prepared me for treating a bunch of different conditions there. But primarily where I think my sweet spot is spine care. So I see a lot of persistent pain when it relates to the spine. But I love the lower extremity, the hip, love the hip. I love treating tendinopathies. I will actually say I do not enjoy post-operative care. I don't know what it is about it, but I love like getting the people who are coming in before surgery, whether trying to prevent it or just, trying to figure out what's going on.
Yeah.
I just feel like that's kind of like where I tend to enjoy most of the time. There's some folks who just love, doing post-op type care. It's just not really where my sweet spot
Yeah.
is. I
Yeah.
don't typically see a lot of those folks, but sometimes, years down the road where they may be having issues still, I enjoy those as well. But
Yeah. Yeah. I'm in the same vein. I feel like, I'm in clinic a lot less than my colleagues who are working next to me, who are there 36, 40 hours a week. And
yeah,
so I try to take on the harder, more complicated stuff because I can. But you said something that resonated with me, which is, as like practice changes and as our ideas are kind of coming out and we're thinking about more contemporary models, something like patient centered, person centered care, it's kind of cool to see this as the provider and then take it to the classroom and really be able to speak to what it's like and what's happening. And maybe nothing has changed, but maybe we're just thinking about things in a different way. But I think that's really important. Before we kind of dive into that topic, which is what you had wanted to talk about today, tell me a little bit about your involvement with the AOMT organization. What's your history there?
yeah, I've been a member in AOMT for years at this point, over a decade. And it's just I love the tight knit networking approach of people who are really trying, I think, to make our profession better, and push manual therapy forward, which I think is important. Not being stuck in one mindset over time, which I think has been really great. So I typically serve in the fellowship realm of AOP. So I'm part of the program director SIG. I've been part of that SIG since I've been kind of working into this position I'm in with fellowship. Then I also serve as vice chair for the Council for Accreditation, which is like a committee that works with ACOMPT for accreditation, consulting, if you will, with the board for ACOMPT, which has been really helpful to really be, keeping accreditation in mind. And ACOMPT has been really good about trying to get input from program directors to better serve their accreditation processes. So, I'm one of the first to complain about something that I think is not working well. So, they've given myself and others avenue to give feedback, and luckily, it's been just a great collaborative procedure that I'm very happy to be involved in.
Yeah. Well, thank you for your service there. I recognize as a board member myself that it's very unselfish work and takes a lot of time, but it's a testament to your desire to continue to kind of push the envelope in terms of education and standards. And I know it's a lot. So, thanks for all of your work with that. Um, so the topic you wanted to talk about was person-centered care. So let's start with that. What do you want to tell us about it? What do you want to unpack about it? What do we need to know?
Yeah. So I think first off, person centered care was like a term I never heard of until actually I started at Bell College. And it came from a discussion I had with the nursing department where they brought up, we were talking a lot about patient centered care. And I remember someone had said, I think it was actually the president of the college, said, actually the term we should be using is person-centered care. And I just remember it kind of struck me as like, that's kind of a different term that I haven't seen reported in the literature, or really just talked about when it came to PT. And lo and behold, it just kind of like stuck around in my head. And I was like, well, does it really need to be called that? Why are we calling it person-centered when we have patient-centered?
Right.
And then over the years, I feel like it's just becoming more and more prevalent in the literature. So I think Nathan Hudding has done some excellent preliminary descriptive work on this. He's published a number of great articles that I think are kind of like your foundational readings you should be doing. And then just last year, as you probably know, Amy, Damien Keeter and colleagues did a nice JOSPT open article on person-centered care, and they did it more specific to manual therapy. But there's a lot of information out there where it's starting to like build this momentum into what exactly is person-centered care. And so, when you look at person-centered care, what it is, if you boil it down, it's really looking at the person that you're who's seeking care as a human. And I think when we when we look at the person across from us as a human being who has values, opinions, beliefs, challenges from a
Mhm.
social standpoint, you know, all those things play into the overall care that you should be giving them. And I think over the years, especially when you're going through training, it's really easy what I call to fall into like a PT robot where you are so focused on your processes and the things that you need to get done during a session, whether it be an evaluation or a follow-up session, that you kind of like forget that this is like a person who's suffering or has a story to tell. It just becomes a very PT centric or clinician centric
Yeah.
care approach. And so, for me, when I was going through DPT school and then when I was coming out in post professional training, especially in fellowship, like I had in my mind, like, I got to get these things done. Like, this is, I'm doing a subjective exam. I need to ask these things in this type of order to develop my hypotheses. And I realized when I was going through mentoring and fellowship, when my mentor, Andrew Bennett, I never forget, I had a patient come in. The patient was late, right? And this patient was coming in and was late, sat down, was like, you could tell visibly shooken that she was like not on time. It was like really important for her. She felt terrible, but she was like coming in and she said, sorry, I'm late, disheveled a little bit. And I just like didn't even acknowledge that the person, first of all, like felt truly bad, but was also like had a hectic day. And I
Yeah.
just
Yeah.
right into like, oh, well, tell me how you feel. Like I totally went into the Mark Shepard, like, let's get stuff done,
The Mark
like,
Shepard show is what you're saying.
yeah. And like Andrew was just like, after the session, he was just like, well, how'd you think you did? And I was like, oh, well, I think I did this and that. And he's like, well, I think you totally blew an opportunity to create, a better rapport with the patient. And
Yeah.
he just went in and be like, you totally didn't see the person. Like, if a friend of mine showed up late and was like really upset about it, I'm not just going to dismiss their feelings there, right? Like, I'm going to probably be like, oh, it's okay. No big
Yeah.
deal. I'm sorry you had a bad day. And then, you continue on. But I just remember that experience being like, man, I just blew the humanistic side of care
Yeah.
because of my own selfish goals and needs. And that's just not, I think, the ideal way to elicit shared decision making, to elicit rapport building, the therapeutic alliance, so on and so forth. So I
But
think,
we also know that in education and in learning, you've got to make those mistakes for it to make an impression. So that was probably a formative experience for you because it stuck with you and you used that to really change.
yeah. And I mean, if anybody who's mentored with Andrew Bennett knows, like, he does not mince words. He's very direct, but
Yeah.
that emotional response, I think, like really solidified it in my brain, and it just like that memory, I think, paired with the readings and hearing this term of person centeredness, just it made me really reflect on like what's the differences between
Mhm.
patient versus person. Where does that drive you? Going forward as a clinician.
Yeah, I appreciate that, but I also think it kind of lives on this continuum of learning, right? So entry level students by nature are in this hypothetical deductive reasoning moment. They can't probably see that person in their entirety, but I
Yeah.
love that we're calling it out because I think when we're in fellowship training and beyond, it has to have a major piece in our patient encounter and in our clinical kind of ritual with that patient. But I love that you're calling it out because the patient piece is just a slice. And many people, my observations over the years have been that people don't want to define themselves as a patient. And
Mhm.
so I love that we're kind of coming around and there's this recognition that it's a person. And that includes all those other pieces of their life, like the woman being late because she had all these other things that were going on.
Yeah.
But yeah, I appreciate how you're kind of making a distinction for us regarding, patient centered versus person centered. Have you changed language in how you educate in order to kind of make this shift? Because I know that a lot of professions are still kind of using that patient centered term, but are you like explicitly making a shift in language, or what does that look like?
Yeah, we're trying to. I think it's easier said than done. I will still use the term patient. I think it's appropriate to do that. I mean, patient by definition is a person who's seeking care or receiving care from a medical professional.
Right.
Um, so, I mean, I think the word patient is fine to continue to use, but I think what I'm trying to do, at least in our teaching, at least at Bellin College, we're very deliberate in actually having a theme of our DPT program being person-centered care. This is
Right.
something that is thematic throughout the whole DPT program. Every class, we try to tie it back to like how
Yeah.
is this really being person-centered. And in the fellowship, I mean, as we'll talk about, I mean, we have a whole person-centered hypothesis framework for how we are truly trying to deliberately and intentionally think about the person as a human and all the things they bring to the table that at least aligns with the literature and how we should drive our decision making in a way that helps drive towards effective treatment.
Yeah. So what tell me a little bit about what that looks like, because maybe some of us and some of the people listening can think about ways to integrate this, into their own training of entry level students or their own clinical practice. So what are some of the flavors of this framework that you speak of, Mark Shepard?
Yes, this framework actually is. I keep wanting to reiterate that this is really nothing new. At least I think. I think a lot of you look back at like Jeff Maitland's probably been doing this in his own mind
Yeah.
for years. And I was just listening to a podcast with Mark Jones, the clinical reasoning kind of
Oh,
guru.
love it.
And I was listening to him talk about, like what does clinical reasoning look like? And as I'm listening to him, I'm like, gosh, this sounds just like what we're using in our framework. However, we just wrote it down in almost like a formula of sorts. Okay. So,
Okay.
and the reason why we've done it this way is because when you're teaching it, just like you teach a math equation, you use formulas, right? And it sounds like, oh, this sounds exactly what you don't want to do with person-centered care, where it's like very like, rigorous. But what we find is with using a kind of formula-based approach, it allows you to have very clear thinking, at least with your hypothesis development. So really our first step in the process of what we call our person-centered hypothesis is figuring out what the type of pain phenotype a person may be presenting with. And so
Okay.
typically I find that this is a mixed, most cases are mixed.
Right.
And when I talk about pain phenotypes, I'm talking about, does a person have nociceptive, neuropathic, or nociplastic, or some mix of pain phenotypes? And the reason why we start there first is because it's really easy to do very quickly. If you look at the literature on how to define these things, which I'm not going to go through right now because that's will take quite a bit of time, but you can generally glean a person's pain phenotype really quickly. And the reason we do this so quickly too is it kind of helps us understand the nervous system's kind of like response to what stimuli you may give to them. So if someone has nociplastic, primary nociplastic, they're probably going to be relatively sensitive. I'm going to have to change my exam a little bit to be cautious of that. I may have to do quantitative sensory testing versus like my traditional kind of manual exam. So it just helps already frame in your mind, okay, what's the nervous system look like for this person in front of you?
Question. How much
Yeah.
of that is coming from patient-reported outcome measures, the patient interview? So when you're thinking right in the beginning about which one of these phenotypes might this person fit into, what is the data that you're bringing in to make that decision so you can start the hypothesis early?
Yeah, I mean, it's honestly, it's coming a lot from the intake paperwork. I mean, nociplastic pain, you can tell, the first step is looking at how long they've had symptoms. 3 months or more, you're already thinking, oh man, there might be some type of nociplastic pain state or mechanisms going on.
Yeah.
The body chart to me is absolutely critical. Like you have some of those folks who come in and they have shoulder pain and it's like they have that circle. It's like right here, right over the area. It's like very defined versus what I call kind of like the Sasquatch, where they like draw in with like real like intense, the whole limb. It looks like a arm of Sasquatch because it's like outside the
Yeah.
line,
And
like
then
that.
the paper rips because
Or they circle the whole limb. Like that's not
yeah,
a dermatome. That's
yeah,
that is a whole regional thing. That to me tells you very clearly what's going on once you confirm in the interview. So yeah, it's really the intake work, the body chart, and then confirmations as you're interviewing the person.
yeah. Okay, so then what's that next level of triage for this framework?
Yeah, so pain mechanisms first. Then we kind of go to what we think of as our traditional hypothesis development
Yeah.
process. When I was going through mentorship, we'd always kind of step out of the room and I'd tell my mentor, well, I think this person has hip osteoarthritis. I think this person has movement coordination impairment of the low back or lumbar spine. So what the problem is with that is that it is very pathoanatomically driven. But we
Yeah.
know the biopsychosocial model, yes, we need to think about all three of these types of things, but we have to remember there's a biologic thing going on. If someone has hip OA, there are biologic, medicalized things from a pathophysiologic standpoint that are going
Yeah.
on that helps you with
Fair.
pattern recognition, right?
Fair.
So we go to that next because that's typically where our brains go as PTs to
Right.
say, okay, if this is hip osteoarthritis, then we should see, morning stiffness. We should see limitations in their range of motion. Those types of things start to conjure up very quick pattern recognition so that it guides you to say, all right, in my subjective exam, I should be asking, well, how is your symptoms? How are they in the morning? And if they're saying I'm stiff or painful in the morning for, an hour period of time, 30 minutes, whatever, then that helps you build that hypothesis there. So we
Yeah.
kind of we define that really as being like, what's the pathoanatomic diagnosis you may have, or the diagnosis described in the literature, and that might be what we see in the clinical practice guidelines for low back pain, where they're not very like patho titled, but they might be a classification like mobility impairment or something along those lines.
So are you saying that this framework is kind of trying to marry the pain phenotype with the pathoanatomic diagnosis in order to kind of continue to move through your hypothesis
Yep.
generation? And then where do you take the, you're calling it person centered. So where does that come in? Like the values of the patient or their lifestyle or the social determinants of health? Where is that fitting? Maybe we should have had a whiteboard or
Yeah, no, I'll have to give you a diagram or something because it's easier to see, I think, from a like written out. But
yeah.
um, to really get the person, there's kind of the last part of our hypothesis is what we call influencing factors.
Okay.
And the influencing factors can be both positive or negative in nature because not what we typically think of the complicating issues. They have fear avoidance, catastrophizing thoughts, maybe significant anxiety, depression. It could be like social issues. Maybe they are struggling with finances. They lost their job.
Yeah.
Uh, they had a divorce or something like that. That complicate things. But it could also be positive, like, hey, I heard you were the best PT around. The doctor said to come to you. I'm so excited to be here. Like you can't discount the placebo in something like that, right? Or positive expectations for, I think I need to, have this type of treatment, whether it be like a manual technique or dry needling or exercise, what have you. They may come in having that expectation that you're like, hey, I can do that, and so what we really encourage clinicians to do is say, hey, let's intentionally think about those things and how that may drive your care. Because if someone has high fear avoidance or high catastrophizing thoughts, you need to address that. And in
Yeah.
some cases, those things are the primary impairments. We call them kind of like mental impairment or cognitive, I should say, impairments where
Sure.
they could be maladaptive. And so when we look at the totality of the hypothesis, we have pain phenotypes, a pathoanatomic aspect of it. We also call out what we call in the environment of, which is maybe when two things are going on. A typical example is shoulder and neck, or neck and shoulder. You know, it allows us to look at two possible things at once, and then finally influencing factors. So all of those things are very intentionally written down and really thought about on how can we as a clinician address these things in a very efficient and hopefully effective manner.
So, what makes this a little bit different from, we're both educators, so I'll define some of the things, but the ICF model. So, how is that either complementing or replacing, or what is it additive to the ICF model, which is the International Classification of Functioning Disability, which talks about patients' participation, activity limitations, or impairments, or another framework of hypothesis generation and subsequent decision making. And I'll say decision making because I think that's different from clinical reasoning, like the HOAC 2 model. Like, where is this kind of aligning or fitting in or building upon or replacing? Tell me more about that.
I think it complements the ICF model. It really allows you to use ICF language if you were to do that.
Yeah.
I should say that this hypothesis algorithm or framework is really meant for people who are in pain. So it's not something that I think could it probably in some way could be adapted to different populations, but this is really specific to musculoskeletal type of pain
Okay.
condition. Now, I have used it in my own mind without people who have pain, and you just kind of take the pain phenotypes off of it. But I think to me, it really allows you to look at the ICF and say, what are some of the structures that could be involved? What are the impairments that could be involved? And then most importantly, what type of contextual factors are involved in this particular case? And person-centered care really just says, each person sitting in front of us has a unique lived experience that we need to look at. And I think we all recognize that. Again, this is nothing new. We've been saying this for years at this point. It's just, I think when we get into the clinical trenches, it's so easy to focus on the pathoanatomy only. And yeah, there's some fear avoidance or there's some depression, anxiety that's involved, but we're not putting it together and mixing it together to say, all right, how do we prioritize each of these things and come up with a plan of care that allows us a very systematic and structured way to address these things?
Yeah. It sounds intriguing because, as we both know, treating people with persistent pain, or sometimes what we call more clinically chronic pain, is incredibly challenging. And I agree that somehow we want to, we feel like there's a cookie if we get to the pathoanatomic diagnosis, or there's a prize.
Yeah.
And in our brains, I feel like, and maybe I'm speaking for myself, you're doing your tests and measures, and you're changing your hypothesis, and you're trying to recognize patterns to get to the pathoanatomic piece. And then maybe how we manage pain has been additive. Like it's one of the impairments. But I like how you're saying that patients, maybe more so in the orthopedic setting, but patients presenting to us, usually their primary complaint is pain. It's not because they have trouble doing a thing. Oftentimes I think that there's pain associated with it. So I like that you're just calling that out and putting that like at the top. And then the pathoanatomic diagnosis and maybe the subsequent, clinical practice guideline information is there too, but it's not at the top. It's kind of fit in there somewhere else. Am I summarizing that adequately?
Yeah, and I think the thing that I've reflected on in my own hypothesis development in the clinic, like what I'm doing when I'm treating a person, in my mind, I'm like, I had been going to pathoanatomy, like I talked about, what is the pathoanatomy diagnosis? And then as PTs, we're so quick to say, oh, well, pathoanatomy in an MRI doesn't necessarily, mean that person's going to have pain, right? There's plenty of asymptomatic people with pathology. And we are so quick to like cast stones at other professions that highlight that. And what do we do when we come up with hypotheses? We are using the same nomenclature that we are criticizing other people doing.
Yeah.
And so I think this person-centered approach respects that there is pathology, and pathology leads to patterns in presentation, but also saying, guess what? There is a nervous system involved and there's a brain involved. And we need to think about how all of this comes together so that we can try to, like I said, systematically have a game plan on the plan of care. And
Yeah.
honestly, it's not easy. Obviously,
Yeah.
it's easy
Yeah.
when things are going. You have people who are excited to be there. There are nociceptive pain mechanisms and a pretty straightforward diagnosis. But unfortunately, now the people we're seeing are only becoming more and more complex.
Yeah, agreed. And one of the things that tried to more tried to be more conscientious about in the clinic is really fleshing out social determinants of health, barriers to care. What are you comfortable with? What have you heard? How do you feel about your diagnosis? Like I want to know how medicalized they've become sometimes because I work in a hospital, outpatient hospital system. And so sometimes they just have laundry lists of medications and diagnoses, and I want to know how they feel about that. How do you take that element of what the patient has to say, like all of those pieces? How does that fit into your framework? Where do you start eliciting from the patient what their ideas are in terms of how to best manage them?
Yeah, so I think in our interview process, we always stress to the fellow in training that they need to elicit the person's perspectives. That's part of our communication framework, and part of that is asking, what do you think is going on? Like that simple question is so helpful, and then from there, asking about their perspectives on their condition, and like you said, if they're on a lot of medications or they're telling you things in the interview that makes it seem like this has really had a dramatic effect on their life. We need to explore that. That's
Yeah.
important. And, what are their goals? If there's one thing that you want them to get back to, what is that going to be? If PT is successful, what does that look like to you? And then thinking about their expectations. Is there something that you feel you need from myself as a PT throughout your time with us in PT? Maybe there's been something that they had in the past, and it may be ultrasound, that they say the person really values. And so we just need to understand those perceptions, but those components coupled with what you find through the use of your outcome measures or questionnaires.
Yeah.
We typically use we advocate for promise-based measures,
Yeah.
pain interference and function, as well as looking at the pain catastrophizing scale, Tampa scale for kinesiophobia, which looks at some of these cognitive beliefs. I think we get a lot of information from that data there, and then that all comes together in influencing factors of our hypothesis, and that's why it's so important for us to say, all right, out of all the beliefs that this person has, which ones are most notable right now that I need to address day 1, 2, 3, and then where do we go from there?
Yeah.
So that's kind of how we explore those things and then integrate them into a deliberate hypothesis.
Okay. Okay. So a question I have, you interact with a lot of fellows in training, you interact with a lot of individuals who are coming through your DSC program. What are some of the things that maybe we need to consider in entry level education and residency education based on what you see in the individuals that are coming to you for fellowship training? So how has some of this and what you've learned about fellows, how can that inform us better as educators in other areas of physical therapy education?
Yeah, my answer, Amy, is going to be extraordinarily boring, and it's not it's not anything like. No, sorry, everybody that's listening. I will say I think hammering the basics is critical, and what do
Okay.
I mean by that? The basics of communication strategies, the basics of patient handling.
Yeah.
To me, when I see someone, and if you think about, if you're listening to this, or even you, Amy, I'm sure you think about like that PT who you're like, like this is a stand-up citizen right there, like a great PT. And you look at what they're doing and you just say, wow, like when they take range of motion, they're doing it really well. The
Yeah.
setup looks great. The way that they communicate, their hands, the way that they handle the person, their touch looks confident yet not pokey or whatever.
Yeah.
Me, I just think reiterating, and I do this so much with our fellows, is, experts do the basics extraordinarily well. And
Yeah.
I used to think when I came into fellowship, it was all about the fancy
New.
techniques,
Fancy.
yeah, being, knowing, all more is better type of approach. And I've learned over the years, less done better is
Yeah.
probably better. And the basics to me, like, and maybe it's just me, but when I am using like certain thrust techniques, I'm not doing like 15 different techniques. I'm usually using a handful of them that work fairly well on 90% of people.
Yeah.
And to me, it's just not trying to overload by quantity and be better at your quality of the basic things that we do, and that makes
Yeah.
me less overwhelmed and more confident in the basic stuff.
I like that. And especially a topic that I'm interested in and studying from a clinical standpoint currently is what is the power of some of these contextual factors? What's the power of the therapeutic alliance, the interaction, the communication, the rapport? Might it mean more, in terms of generating our outcomes than what we're actually doing with our hands? And so I really like that comment because I do think from the student's perception, more is more and more is better and fancy is sexy and
Yeah,
fun. But I agree that maybe being more refined with our students in those basic skills that include how do you effectively integrate communication into the hands-on piece and into the examination and into that whole Jared Powell calls it the ritual, which I love that word because it is a ritual. I love that description. I mean, but yeah, I really appreciate that because then you have, I believe, more room if there's a little bit more homogeneity in those basic things like communication, skill set, basic reasoning, then you can really take off in fellowship training to really build on that.
yeah,
So, what are like three takeaways? Whether someone is just everyday clinician, educator, researcher, give me like three takeaways that you want people to think about in terms of person centered care or unique ways to hypothesize, this pain phenotyping
yeah.
component bringing in. What do you want us to know?
Yeah, so I think my first takeaway is remember that we're humans here, both yourself as a clinician and the person who's seeking care. It's okay to communicate things that you're still uncertain about with a person and understand that a person who's crying, console them. and and not be stuck into thinking I got to get this done to document for insurance purposes. Like we need to be greater than that. We need to see the humanistic side of care.
Yeah.
Number two, don't get stuck in being a PT robot. And that kind of builds off of the humanistic side of things. Clinical practice is so messy. It is so messy. And I never appreciated that because when you read case reports or you read a randomized control trial, it looks so clean. It's like,
Yeah.
why
Yeah.
can't I just go in and do that same thing? It's not that way. Patient care is messy and it's gray. And that's what's hard about it is trying to add a standardized reasoning approach to something that's so tough to define and tough to try to reason through. And it's
Yeah.
very easy to rely on being a robotic type of PT where you're not, thinking about all the other things that come to the table. And then finally, I would say have a process. Um,
Yeah.
have a process to be systematic in your clinical care. I think it's too easy. It's easy to fall back on, just doing stuff just because we can. So
Yeah.
I think challenging yourself to have a process is what's key.
Yeah, I think that's fair. And I think as clinicians who've been practicing longer, myself 24 years, almost 25, I don't know how long have you been practicing?
Uh, 14.
14. So
Yeah.
it's really easy to fall back on pattern recognition. And that's kind of where we evolve to in terms of our thinking and our reasoning. But I like that you're saying that we should probably more explicitly try to use or integrate frameworks, because if we're mentoring, if we're teaching in any capacity, we have to hold ourselves to the same standard. And even though I think oftentimes we use pattern recognition to see things and then implement subsequent interventions, things can still get missed.
Yeah.
And unfortunately, I think it's the patient that gets missed, because the pattern that we're recognizing is more pathoanatomic impairment driven.
Mhm.
And so I think you're absolutely 100% spot on that probably all should be integrating some of these components of frameworks or thought processes into our practice, so we don't miss the person who's
Yeah.
sitting there in front of us as
Yeah.
human.
Yeah. Yeah. Totally.
So what else is on tap for you? What are you working on as we kind of close up? Anything interesting that we should all know about and follow you through?
Well, yeah. Well, I think number one, I'm working with the team. Amy, you and I are working together on this to try to get more out about what does this person-centered hypothesis framework look like. We've been playing with it, in our fellowship program for the past 5 years, and
Wow.
it's gone through different iterations. And what I love about it is it's being used by real clinicians day in, day
Yeah.
out,
Yeah.
and they've given us feedback on how to utilize it, what seems clunky, what seems right. Hey, this is helpful. We use it as our mentoring kind of hallmark of how to utilize it in a mentoring uh, scenario.
Okay.
So we're hopefully trying to get the word out, I think, is our next step, and to try to publish some work. So that's been a focus for me,
Yeah.
at least for this.
Yeah. And thanks for pulling me into that. It's so fun to work with different. I mean, you and I have worked on a couple of projects together, but it's so fun. I love hearing about how other people think. I love hearing about what they're doing. I love the people like yourself that are pushing the envelope and really trying to move the needle in terms of education. And you have to disseminate. You have to disseminate what you're doing so other people are privy to your ideas and can hopefully move towards adoption. So, thanks for taking the ball and rolling with it, even though we're all, busy doing different things. I will never say no to you. I'm saying, although there's probably a situation where I would say no, but I probably wouldn't, because we have a good time working together. And I think we think similar, but, different enough that it makes it enjoyable. So,
Yeah.
gosh, I really appreciate your perspective and everything that you're bringing to the AMT membership and others about this person-centered care topic. And so I look forward to seeing how some of your projects evolve and hearing more about what this looks like in a couple years, when maybe you have more data about how this has impacted fellows in training and their future clinical practice. So this
Yeah.
is great. I love the topic, and thanks for coming today.
Yeah. No problem, Amy. Thanks for having me.